Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to pretty comprehensively go through the neurology medications that you're going to have a typical nursing pharmacology course. We're going to start with going through degenerative diseases such as Alzheimer's and myasthenia gravis. Then we're going to move on to some muscle relaxants and then end with antiepileptics and some sedatives and paralytics. So let's go ahead and get started. We're starting with neurodegenerative diseases. And the first thing you have to know about the pharmacology here is that these diseases are generally not curable. What we're trying to do is we're trying to slow down the progression of the disease and hopefully treat the symptoms to make it more survival or more tolerable and improve the patient's quality of life. One quick note before we get into this, there is a CAM over here. It's called ginkgo biloba, and this is used by many patients for memory and cognitive issues. Again, I'm not going to go any more into CAMs than that. We're just going to leave it at that. So the first class of drugs we have are the acetylcholinesterase inhibitors. We talked about this in another lecture. Acetylcholinesterase inhibitors block the body from getting rid of acetylcholine. So acetylcholine is the primary cholinergic neurotransmitter. Acetylcholine esterase is the enzyme that gets rid of acetylcholine as part of the body's natural processes. And this drug class, acetylcholine esterase inhibitors, prevents the body from getting rid of it, thereby increasing the level of acetylcholine. We have a bunch of different drugs in this class. We have donepezil, galantamine, and others. These drugs are generally considered primarily meant for Alzheimer's disease, but they do have a surprising number of uses. Some of these medications are used for myasthenia gravis, that has a little double star next to it. Some of them are used as a neuromuscular blocker reversal, again with the double star next to it. There's also, if you skip to the end of this section, there's another medication, ecothiopate, which is a drug in this class that's only used for glaucoma. There's also physostigmine, which is a drug in this class that's used to treat anticholinergic toxicity, which we talked about in a previous lecture when someone gets too much atropine. So we understand the mechanism of action of how this works. We talked about the indications. You should already have picked up on the fact that since this promotes the amount of acetylcholine, that's going to mean it's going to promote the parasympathetic response. So we may end up with sludge BBB, which is what we also call the cholinergic side effects. That's going to be your salivation, lacrimation, urination, defecation, etc. Basically fluid leaking out of every orifice in the body. So that's our first class of drugs, the acetylcholinesterase inhibitors. Next, we have our dopaminergic drugs. These are used for Parkinson's disease. And most commonly, we have levodopa carbidopa, which is called Sinemet, or levodopa carbidopa entacapone, which is adding on a third ingredient. A little bit about the mechanism of action. Levodopa is a key component for the body to produce dopamine for dopamine synthesis. When we add on carbidopa, we're increasing the efficacy of that levodopa being used to produce dopamine. When we add on entacapone, which is a COMT inhibitor, we're going to talk about it separately as well, this medication prevents the breakdown of levodopa. Again, all of this is about getting as much levodopa as possible to result in the production of more dopamine to increase the patient's dopamine. What do we use this for? This is a Parkinson's medication, so we use it for Parkinson's disease and Parkinsonism. The side effects of this medication are nausea and vomiting, which you see in so many different drugs. We have dyskinesia, orthostatic hypotension, as well as psychosis. Again, for each of these, remember different things you have to know: nausea and vomiting, educate the patient. Dyskinesia, definitely educate the patients that they don't freak out if they have those symptoms or if they don't have resolution of those symptoms. Orthostatic hypotension, remember things like that. We're always going to tell the patient to get up slowly from a seated position. Psychosis, we might actually want to educate family and other caregivers about what that is and how that manifests itself and what to do in the event that that happens. Levodopa carbidopa is considered the most effective medication for the treatment of Parkinson's disease. It doesn't mean we're always going to go there. If a patient has really mild Parkinson's, we probably won't use this, but it is the most used and most effective medication. In order to treat the nausea, we do educate patients to take this medication with food. There's something called the wearing off effect that we discuss in Parkinson's, even though it can honestly exist pretty much anywhere. But the wearing off effect is where patients' symptoms come back when it's coming up time to their next dose. And what we do in that case is we either narrow the dose window, so we take the medication earlier, or we increase the dose, or sometimes this is where we can add on something like the entacapone to increase the effects of that medication. Next drug class we have are the dopamine agonists. This would be something like pramipexole or apomorphine. These medications are agonists of the dopamine D2 and D3 receptors. These are used for Parkinson's disease and also for restless leg syndrome. Again, you have your usual side effects: constipation, nausea, dizziness, drowsiness, and insomnia. And again, we're going to educate patients to take this with food to deal with any of those side effects. Next, we have the MAO B inhibitors, and this would be a drug called selegiline. This blocks exactly what it sounds like, MAOB. What do we use this for? Again, we're still on Parkinson's disease. This has a side effect of insomnia. You should know that any drug that has a side effect of insomnia, we should always educate the patient to take it in the morning. This drug, the MAOB's inhibitors, just like the MAOI's inhibitors, the monoamine oxidase inhibitors that we have in mental health, if you've already watched that lecture, same thing here. Both of these should not be taken with tyramine or foods that contain tyramine. And this medication, because it is structurally similar to that MAOI that we deal with in mental health, and for the same reason, we do want to be careful giving this to patients that are already taking TCAs or most of the other mental health medications. The COMT inhibitor, we talked about this as an add-on ingredient for levodopa carbidopa. This is the entacapone, and this blocks the breakdown of levodopa. Next, we have an anticholinergic here for Parkinson's disease. If you're going in order of the videos, you might have already seen this. This is specifically going to be benztropine. This works by blocking cholinergic receptors. Again, it's an anticholinergic, and specifically this one is used for Parkinson's disease. It's also used for EPS, extrapyramidal symptoms like tardive dyskinesia or akathisia that a patient developed because of a medication that they're taking. Medication is primarily used for the specific Parkinson's symptom of a tremor. And again, since this is an anticholinergic, it would have those anticholinergic effects, the dry mouth, dry eyes. Again, as a nurse, make sure you're a nursing student, rather make sure you're ready for those types of questions. Dry mouth, so patient should suck on a hard candy. Dry eyes, patient might need to carry drops with them, things like that. Next, we move on to multiple sclerosis. And over here, we have the immunomodulators, specifically interferon beta 1A and beta 1B. The mechanism of action of how these work in terms of multiple sclerosis is not exactly known, but we do use it for multiple sclerosis. This drug class of immunomodulators, we do also use interferons in infectious disease as an antiviral, and you'll learn about that in the infectious disease if you haven't already. This class of drugs is by injection only, so you may need to do some therapeutic communication to get the patient on board with that if they have an adverse attitude to getting needles. This medication class is known that it can cause flu-like symptoms, and it is also hepatotoxic. Remember, anytime you see hepatotoxic, that means keep an eye on the AST, ALT, keep an eye on right upper quadrant pain or jaundice, things like that. This medication is very common to cause those flu-like symptoms, so we do often pre-medicate the patient with something like ibuprofen before we even give the drug, especially if they've had that reaction in the past. And these immunomodulators are the first-line treatment for multiple sclerosis. There's a lot more to discuss with multiple sclerosis. Sometimes we use monoclonal antibodies. Sometimes we use immunosuppressants. There's also different types of multiple sclerosis, relapsing, remitting, et cetera, that are beyond the scope of this lecture. Next, we move on from the degenerative diseases to the muscle relaxants. So we start with the official class of musculoskeletal relaxants, which would be drugs like baclofen or methylcarbamol, cyclobenzaprine. The mechanism of action of these vary by drug. Some of them inhibit GABA, some of them do other things that act in similar ways to tricyclic antidepressants, but we use these for muscle spasms. So there's gonna be lots of different indications where we use this. The side effects of this medication, these can be a CNS depressant. Again, some of them do act on GABA, which we know is what causes CNS depression. Some of them can cause blurry vision, dry mouth, angioedema. So we do want to educate patient about those side effects. These should not be taken with alcohol or any other CNS depressant, again, because of the overlapping effects, which can result in extreme CNS depression. Another medication that's technically a muscle relaxant is going to be dantrolene. And this medication works by suppressing the release of calcium. We know that calcium is very much responsible for the contraction of muscles. And by suppressing the release of calcium, we get muscle relaxation. We use this for the same spasticity that we just talked about, less commonly than the regular skeletal muscle relaxants. However, this one is also used for malignant hyperthermia, which we're going to learn about in a little bit. Next, we have the side effects and adverse effects of these drugs. Again, would be the same weakness, the same muscle weakness, again, because of the way it works. This also has a black box warning for, not also, but this has a black box warning for hepatotoxicity. Again, so make sure to keep sign out for liver signs, symptoms, and liver labs. And this should, again, not be taken with alcohol or any other CNS depressant. Before we move on from muscle relaxants, benzodiazepines such as Valium, diazepam are very commonly used as a muscle relaxant. And we do have another CAM here as well, which would be capsaicin, cayenne, chili pepper, things like that. And it's used for muscle pain. Moving on, we have Botox, botulinum toxin. And this is used to inactivate muscles. We directly inject it into the muscle we're trying to inactivate. In the case of like cervical dystonia, stiff neck, things like that, overactive bladder. It does also have purpose to use for migraines, for hyperhidrosis, which is excessive sweating, for spasticity, that's that muscle spasm. So we do have a bunch of different uses, and this list isn't even complete with all the different uses that we have for Botox. The side effects depend obviously on what we're doing. It's going to be very different side effects if we're injecting it for overactive bladder versus if we're doing it for cervical dystonia. This medication generally has an onset from a few days to a few weeks, but the duration of effect can last for many months, which is what the patients are going for. Do keep in mind, just like it has a slow onset and long duration, the adverse effects from this can develop both immediately and over the long term, over days or weeks or even longer. Moving on from here, now we move on to our seizure medications. And the first medication we're going to start with is benzodiazepines. Benzodiazepines, again, is also a muscle relaxant, but we're going to talk about it as the primary anti-seizure medication because this is the first line drug for someone who is actively having a seizure right now. The drugs in this class are all the ones that end in PAM, lorazepam, diazepam, midazolam, and so many more. These drugs are a GABA agonist. GABA, you may have learned, are the brakes of the brain. They slow everything down in the brain. So if the brain is hyperexcited, that's why it's having a seizure. This slows everything down. GABA stands for GABA aminobutyric acid, and it's known as an inhibitory neurotransmitter, probably a term that you may see on a test. Next, we have, what do we use this for? We use it for a lot of different things. We already said muscle relaxant, and now we're adding on seizures. If you've already learned the mental health lecture, we use this for insomnia. We could also use it for anxiety, for panic attacks. We use this in the ICU sometimes for sedation. So there's many, many different uses that we have for this. This is a very powerful medication. It is a controlled substance. It's available both PO, IV, IM. It's also available rectal and other routes. It is given, it does have side effects of causing that weakness, fatigue, again, because it's the GABA activate or agonist. It can lower your blood pressure, so you must check the blood pressure before giving it. It can also cause respiratory depression, so you must check your respiratory rate before giving it, as well as monitor both of those throughout treatment. Just like all controlled substances, it does have a black box warning for risk of addiction and dependency. Never take this with alcohol or any other CNS depressant. A whole bunch of the benzos are also contraindicated in pregnancy due to their teratogenic effects. Again, that would be a decision for the provider based on the risk versus reward. Many times, if we're giving this, especially for a seizure, if the patient happens to be pregnant, we might not even know it because they're actively seizing at the time, unless it's obvious that there's a baby there. We do have a reversal agent for this. It's called flumazenol. We don't use this very common. It's definitely fair game for a test question, though, but we don't use it very often, primarily because it does carry a slight risk of causing seizures. And then if the flumazenol caused the seizure, we're kind of in trouble because we can't give our go-to seizure medication at that point. Next drug we have are the hydantoins. This would be something like phenytoin or foxphenytoin. You might know the brand names Dilantin or Cerebrex. These medications prolong sodium channel inactivation. So it makes the sodium channel inactive for a longer period of time, meaning that the impulses have to slow down. They can't be rapid fire, and it stabilizes the brain that way and reduces seizure activity. What do we use this for? Obviously, we use this for seizures. The adverse effects are going to be hypotension and dysrhythmia. So that means if you see dysrhythmias ever, that always means put the patient on a monitor. And obviously, hypotension means monitor their vital signs regularly. Black box warning is that you have to give it slowly if being given it via the IV route. Keep in mind, you guys should know this already as nursing students, pretty much every drug should be given slow IV push. It's pretty rare that we're giving something via rapid IV push. There are specific times we do that, but the rule of thumb is we're always giving things slow, whether it's morphine, benzo, anything. Next, this medication class is known that it can reduce a patient's vitamin K, which can cause bleeding. You'll learn more about that in the anticoagulant lecture. And because of that, we may need to provide the patient with vitamin K if this is a long-term medication for them. Again, we can use this both acute and long-term. This medication is definitely toxic to the local tissue. So if the IV does leak and it ends up getting infused into the local tissue, then we may have an issue there of extravasation. So you do need to monitor for that. This medication is considered teratogenic, which means you can't give it during pregnancy or to a patient that's pregnant. Also, unfortunately, it makes the patient's hormonal contraceptive, let's say their standard estrogen, progesterone, birth control pill, less effective. So on the one side, you can't get pregnant while taking it because it's teratogenic. On the other hand, your medication may not work as well, putting you at risk for becoming pregnant. Again, that's something that has to be worked out with the patient of what's the best option in terms of is there a better method to versus a hormonal contraceptive that wouldn't work as well in order to prevent pregnancy while taking this medication, or do we need to switch them to another medication? That's a little bit outside the scope of this lecture, but the risk versus reward decision would be made between the patient and their provider. The next class of drugs we have are succinimides. These are used specifically for absent seizures. These won't help for standard seizure. They work by blocking specific calcium channels, and they can increase the seizure threshold. That's a good thing. Increasing the seizure threshold means that you're not as quick to have a seizure. Next drug class we have are barbiturates, such as phenobarbital. Again, this is also a GABA agonist. This is also a controlled substance, also used for seizures and sedation. Very similar in many ways to the benzos that we already discussed. Again, it can also cause the same respiratory depression and sedation. This medication, unlike benzos, does have that issue also of the vitamin K issue, just like we discussed previously with the hydantoins. And again, like any GABA agonist, don't take it with alcohol or other CNS depressants. And like we're going to see with a bunch of the anti-seizure medications, they're going to have this issue that it makes your oral contraceptives not as effective. Next drug class we have is valproate. And if you've already taken mental health, you've seen this as a bipolar medication. But over here, we're talking about it as an anti-seizure medication. How does this work? Again, same thing as we had earlier with the hydantoins. It prolongs the sodium channel inactivation. Plus, it also has some aspects of being a GABA agonist, meaning that it slows down the brain. It hits the brakes of the brain. The indications for this would be for seizures, for migraines, and for bipolar disorder. The side effects, very common nausea, pretty much rule of thumb. If it doesn't say anything for side effects, just always assume nausea. It's the number one most common side effect among all oral medications. This does have 3 black box warnings. That's a good test question that can often get asked for nursing students. They are hepatotoxicity, they are teratogenicity. In fact, this is the worst of all of the anti-seizure medications for a female of childbearing age to be on. And the 3rd black box warning is pancreatitis. So you might want to monitor that amylase lipase, and you might want to avoid this in a patient has a history of pancreatitis or alcohol use disorder or something else like that. Valproates also cannot be given to children under 2 years old. I know that's a one-off fact, but that is commonly known, so that is something that's fair game for testing. The next drug we have is carbamazepine, more commonly known as Tegretol. Again, this works by prolonging that sodium channel inactivation to slow down the impulses in the brain. What do we use this for? We use this for both seizures and for bipolar disorder. It does have off-label uses as well that we're not going to get into. The adverse effects of this can have CNS effects, specifically when starting treatment. Generally, these resolve. When you see CNS effects, that's a really broad range of what it could be. It could be things like numbness and tingling. It could be altered mental status, confusion. It really depends. We do put that pretty broadly and expect students to just identify what in general it means when we say CNS effects. Each medication might be slightly different. Again, the same vitamin K issue that we mentioned twice already, and the same issue of the decreasing the effectiveness of oral contraceptives. This again has 3 black box warnings. This one has for SJS10, which stands for Stevens-Johnson syndrome and toxic epidermal necrolysis. These are severe and potentially life-threatening dermatological issues. We also have a black box warning that can cause aplastic anemia, which is obviously a type of anemia, as well as agranulocytosis. Again, I don't know how deep you want to get into with this. It is fair game for a test, so as a nursing student, you should know that. Moving on, we have lamotrigine, more commonly known as Lamictal. Again, the same sodium channel activation. Plus, this one also blocks calcium channels and it blocks glutamate. What do we use this for? Seizure disorder and bipolar disorder. You're noticing some overlap there since these are both neurological issues. Adverse effects, again, we have the same CNS signs and symptoms that you need to look out for. This and the next one, levetiracetam, are the 2 best options for a patient who's female of childbearing age or potentially is already pregnant. We need to figure out their anti-seizure medication for the duration of pregnancy. This does also have that black box warning for SJS and 10. So that means as a nurse, you need to keep monitoring for any signs of any dermatological issues. And again, this has the same issue that it decreases the effectiveness of our birth control. Next, we have levetiracetam, which is Keppra. We don't know exactly how this helps with seizures. We know a little bit about what it does, but I wouldn't expect you to get tested on that, certainly not at the RN level, since generally we just say it's unknown. The indication for this medication, it is used for seizure disorder. It does have some off-label uses I'm not going to get into. Again, the same adverse effects that it could have CNS effects when it started. One of the best, this is, like I said, one of the best options for use in pregnancy. And again, this can also decrease the effectiveness of your oral contraceptives. Next, we have gabapentin. This is a more commonly known medication. Mechanism of action, we're not 100% sure on how it works for seizures or for pain. but it is officially labeled as a seizure medication also for one other official use, which is post-herpetic neuralgia. And then finally, it does have a bunch of off-label uses, very well known that it's used for neuropathic pain, and by some patients it is abused. This medication can also be used off-label for migraine and anxiety. I wouldn't expect you to have to go too much more deep into this medication beyond what's already there. Primarily, this is considered a seizure medication. However, a lot of the use that we have it nowadays is for neuropathic pain. Next, we have topiramate. And a lot of these medications that we're listing, of the lamotrigine, the levetiracetam, you may see these called as newer antiepileptics or second gen or atypical antiepileptics, something like that. Moving on, we have topiramate, which is known as Topamax. Again, you can see the mechanism of action here, that same sodium channel inactivation, plus the blocking glutamate, plus the blocking calcium channels. And this one even has a fourth mechanism of action, which is that it's a GABA agonist. This is used for seizure disorder and migraines. This medication is known that it also helps with weight loss, not extensively, but it does help with that. And sometimes it's actually used for that off label. But this medication definitely has CNS effects. It's considered a very strong and potent medication. It does have a risk of causing suicide for this. It is used off label for bipolar, for eating disorders, and for essential tremor. This medication, once again, can decrease the effectiveness of oral contraceptives. Excuse me. This is not generally considered a go-to medication for seizure disorder. This would be more of a, we're on to our second, third, or fourth medication. Next, we have pregabalin, which is Lyrica. This medication is used for seizure. It's not a very common medication for use for seizure. It's more commonly used for fibromyalgia or for neuropathic pain. It does have several mechanisms of action. It inhibits the neurotransmitters epi, glutamate, and serotonin. Like I just said, it's used for fibromyalgia, for seizures, and for neuropathic pain. Again, the side effects, we have that same CNS effects. Again, these are all neural medications. These are all seizure medications. They're going to mess with your CNS, so they're going to have CNS side effects. This medication actually causes weight gain along with visual disturbances and peripheral edema. And this one is actually a controlled substance, Schedule 5. Next, we have drug classes, drug name is oxcarbazepine. And this medication is mostly not known how it works. Again, with that block in the sodium channels, which calms down the hyperexcited membranes. The same thing we've been talking about. I just wrote it a little bit differently here. The indications of this is, again, this is a seizure medication. Again, the CNS effects. Again, we have the SJS10 or adverse effect that we need to be aware of. What else do we need to know? We need to know that all seizure medications must be tapered. You cannot suddenly stop taking it. If a patient tells you, oh, I've been seizure-free for 10 years, can I stop my medication? No, you've been seizure-free for 10 years probably because of your medication. If we are stopping it, they should always be tapered. A lot of these medications, we saw that it has risks to do with pregnancy. Taking folic acid can sometimes be used to mitigate that risk, obviously to a point. We already said that if a patient is pregnant or planning to become pregnant, we have to make a decision on what's going to be the best option for the patient's health and for the baby's health. We do have a non-pharm option for seizures. I don't really honestly know much about this, but it is in the textbooks that the ketogenic diet may help either in addition to medication or if medication is not working to help reduce seizure activity. And then also most of the anti-seizure medications that we talked about do also carry a increased risk of suicide. That kind of makes sense if we're messing with the patient's CNS, that it can mess with their mental health as well. Next, we move on to our sedatives, and then we're going to end with the paralytics. So moving on to sedatives, we have propofol, the most used sedative in the United States. How does it work? We don't know exactly. We do know that it promotes the release of GABA. Again, GABA slows things down in the brain. How do we use this? It's used for anesthesia, both the induction of anesthesia and it's used for sedation. This medication does carry a risk of respiratory depression and hypertension, in fact, a pretty severe risk. If a patient does get too much of this, they will absolutely drop their blood pressure and drop their respiratory rate. This is definitely IV only. There is something called propofol infusion syndrome. I don't know that you get tested on this at the RN level, but I threw it in here anyways. And that can occur, and it involves acidosis, cardiac renal failure, and rhabdomyolysis. So if you see any of those on a test, it's guiding you towards recognizing that propofol infusion syndrome. This medication is also something that you need to be watching the patient very carefully. It is only used in the ICUs or other high acuity units. This can be given via a direct injection an IV push if we're using it for a sedation. That's an off-label use, but you may see this given sometimes if we're trying to do, let's say, a shoulder reduction or something like that. You may see this on a one-off case given not via the traditional IV infusion. Next, we have etomidate. Etomidate, the mechanism of action, it's a general anesthetic. It's used to induce anesthesia, not to maintain anesthesia. It's IV only. Again, I don't think you'd get any more into that at the RN level. The next drug we have is ketamine. The mechanism of action here is this is an NMDA receptor antagonist. It blocks NMDA, meaning it's a dissociative anesthetic. It sort of separates the body from what the control impulses of what is going on in the rest of the body. That's why it's called a dissociative. Everything else that's going in the body no longer gets processed in terms of the signals. So what do we use this for? We use this for anesthesia. The side effects of this medication can be delirium. It could be hallucinations. There's actually a pretty extensive list. The patient can go completely out of it when giving this medication. This is a controlled substance, and like all controlled substances, the same black box warning for abuse and dependency. This medication, unlike almost all other sedatives like the propofol and the benzos, this one will actually bring up your blood pressure at least somewhat, or hold it steady. It wouldn't drop it like the other ones. So that is often a consideration when giving this medication. This medication can be used off-label as a pain medication, and it can also, in that form, it's also used both IV and PO in order to help that patient with their pain management. However, when we're talking about this most commonly, and as far as its labeled use, it is used for anesthesia and for patients that need that disassociation. Next, we have the next medication, which I honestly can't pronounce. I'm going to stick to the brand name, which is Precedex. This is another sedative that's commonly used in ICUs across the United States. This is used for sedation, and it's also used for agitation related to bipolar or schizophrenia. I've only ever seen it used for sedation itself. It does have the same adverse effect of hypotension like a lot of the other sedatives. This one can also cause some bradycardia. Patients may develop a tolerance to this. And the last note I have on sedation is that benzos are also on sedation. So benzos have been all over this lecture as a sedative, as a muscle relaxant, and as a anti-seizure medication. Finally, we move on to the last section, which is paralytics. Paralytics do exactly that. They paralyze a patient. So they have two different ways that they do it. We're going to start with the first one, the non-depolarizing. Non-depolarizing paralytics include becuronium, rocuronium, pancuronium. All of these are considered extremely high-risk medications. All of these will kill your patient if used incorrectly. The mechanism of action is that they inhibit cellular depolarization. If the cells can't depolarize, they can't move. The indication for this is to block the patient, generally for intubation, so that we can place the patient with the endotracheal tube and put them on mechanical ventilation. The duration for these is roughly 30 to 90 minutes. Some work longer than others. Vecuronium is a little bit longer than rocuronium. Again, you definitely don't need to know those details at the RN level. All of these patients must be mechanically ventilated, period, no exceptions. They are paralyzed. Their diaphragm is paralyzed. They are not breathing. So you do need to mechanically ventilate this patient. We do have a reversal agent that we can use if a patient needs it. Plus, we have another reversal agent that we talked about the very first drug class of this lecture. Go back, see if you remember what that is. Finally, the last drug name we have is succinylcholine. This is another paralytic, but this is a depolarizing paralytic. I would suggest knowing the difference between the polarizing and the depolarizing and the non-depolarizing. That's definitely fair game for a test question, even at the RN level. This works by inducing depolarization of the entire musculoskeletal or muscular system, meaning that every muscle is going to decrease activate its release its action potential, making it that the patient is no longer able to execute any movement. Because of the way this works, this doesn't block anything. It just releases all the potential. The body will build up that potential again. Usually in about 3 to 5 minutes, the patient will be able to move again. So that's an advantage or a disadvantage. If we want the patient really quickly to be able to move again, let's say we're trying to intubate them, but we're not sure if we'll be successful, we'd rather them have a short-acting one so that they can start breathing again on their own within a few minutes. If I want long-acting paralytic, this is not the one that I would use. This does have a few issues with it, specifically hyperkalemia and malignant hyperthermia and fasciculation. So it could cause malignant hyperthermia, it could cause hyperkalemia, and it always causes fasciculations because that's how it works. Malignant hyperthermia, for those of you who don't know, presents with muscle rigidity, fever, and hypercapnia. And you should go back and see what drug we learned about earlier in this lecture can treat malignant hyperthermia. This is the only available depolarizing neuromuscular blocker, is just this one, succinylcholine. If you happen to know that a patient has hyperkalemia, then this will be contraindicated. Again, very often when we're giving this, we wouldn't have that information. And again, like I said previously, this absolutely requires the patient to be on mechanical ventilation because for the duration of the drug, the patient is paralyzed, unable to breathe. Finally, last and certainly most important, any patient who is getting a paralytic must, no exceptions, be receiving an analgesic and or a sedative because you are paralyzing them and they can't move anymore. That does not help their pain. That does not help their level of consciousness. It still stays exactly the way it was prior to the paralytic. So if the patient had any level of consciousness beforehand, that continues with the paralytic. So if they can feel pain, you're going to put them, paralyze them. They're not even able to report that pain to you anymore, but they're certainly still going to feel it. If you have any questions, please reach out. Have a great day.